Good evening to everyone present here with us today. This is Shreyan from IJCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, let me welcome Dr. Keshava Murthy CV. Sir is MBBS, MD General Medicine, DM Cardiology, DNB Cardiology, and consultant at Manipal Hospital, Mysore. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is sudden cardiac death in the young. Time to rethink screening. Now, without any further delay, I would like to hand over the session to him so that he can begin with his presentation. Over to you, sir.
Thank you for the opportunity and a warm welcome to all the participants. I'm sure you are spending your time here to learn something and it will definitely be useful in day to day practice. The commonest cause of sudden cardiac arrest or sudden cardiac death is ventricular arrhythmias. So, arrhythmic deaths are the ones which contribute more than 50% to sudden cardiac deaths in the young. So today's talk is in particular about sudden deaths in young people, which is a focus of interest now, especially if you see in the social media, there are a huge number of sudden deaths, even in some of the celebrities, so which has aroused the interest of the population. And especially there was a sudden spurt of deaths in the 30s or 40s, people in the third or fourth decade of life post COVID, which raised some concern about the COVID disease or whether it was the COVID vaccine, but nothing has been attributable to anything. But there has been a surge of sudden cardiac deaths, as also are the risk factors for cardiac disease and sudden deaths. So we should take it as a whole rather than trying to bifurcate that. So in today's 20 or 25 minutes talk, we'll see how we have a new look at the sudden cardiac deaths with a special reference to the young population and how we can prevent that. So this is one sort of stark statement. Death is always sudden. However long one has to wait, death is ultimately sudden. But when it occurs suddenly in the younger population, especially second, third, or fourth decade, or sometimes in children, it causes a huge concern and alarm and a lot of distress for the close, near, and dear ones. So let us see how we define sudden cardiac death. Sudden cardiac arrest is a sudden cessation of normal cardiac activity with hemodynamic collapse. Sudden cardiac death is sudden natural death presumed to be of cardiac cause that occurs within 1 hour of onset of symptoms in witnessed cases and within 24 hours of last being seen alive when it is unwitnessed. And sudden cardiac death in autopsied cases is defined as the natural unexpected death of unknown or cardiac disease. So there are a lot of ambiguities in the definition itself because, as we know, in many clinical situations, it is impossible to ascertain how this death could have occurred, especially when there is no witness. When there is a witness or a bystander and the person is brought to the hospital, then it is easier to make some kind of a conclusion about the circumstances of death, but otherwise it remains an ambiguity in many of the cases. Sudden unexplained death, unexplained sudden death occurring in an individual older than 1 year, it just causes called as a sudden death, unexpected death, unanticipated death. So SIDS and sudden arrhythmic death syndromes are also defined like this in the various guidelines. SIDS, unexplained sudden death in individual younger than 1 year with negative pathological and toxicological assessment and negative forensic examination, which we know in many of the situations in India, it is not a practical thing to do. And SADS or sudden arrhythmic death syndrome, unexplained sudden death occurring in an individual older than 1 year with negative pathological and toxicological assessment, synonymous with autopsy negative sudden unexplained death. So we know there is a multiplicity of terms because we cannot give definitions to the undefinable. As I said just now, in many instances, the circumstances are unknown. A person is found dead, and we have to derive certain information. If there are bystanders, it's good enough, but if there are no family members or bystanders, it occurs in an isolated place, you are not able to give it a definition or a meaning. So, what are these ventricular arrhythmias which raise our concern whenever an individual dies? As cardiologists and physicians, we know that ventricular arrhythmias are the ones which are the most mortal. They start off as ectopics, ventricular bigerminy, non-sustained ventricular tachycardia, VT, torsade, and of course the most mortal of them all, which is ventricular fibrillation. Some of them are innocent, like unifocal ventricular ectopics in young individuals, which especially if they disappear on exercise, they are said to be benign ectopics. But even if they occur more than 5%, they contribute to more than 5% of the total heartbeats in 24 hours. They can cause cardiomyopathies, or they may be a harbinger of some underlying myocardial disease, either cardiomyopathy or infiltrative disorders, or genetic disorders which cause cardiomyopathies as an underlying disorder. Of course, non-sustained ventricular tachycardia, VT, torsade, and ventricular fibrillation are all very mortal arrhythmias, and they have to be recognized and treated very quite early. So, as opposed to sudden cardiac death, syncope has different definitions. Unexplained syncope, transient loss of consciousness due to cerebral hypoperfusion, and arrhythmic syncope as above, but highly suspicious for intermittent bradycardia, rapid SVT, or a ventricular arrhythmia. So this is what as a 50 is called as the 50% rule to understand what is sudden cardiac death. Sudden cardiac death accounts for about 50% of all cardiovascular deaths, and sudden cardiac death is the first manifestation of coronary artery disease in 50% of the cases. So this is the 50% rule. So 50% of all CV deaths, and it may be the first manifestation of coronary artery disease in 50% of the cases. So it's very difficult to kind of anticipate, predict, detect, and prevent. So that is the most important challenge in sudden cardiac death, as most of the events occur within 1 hour in a previously healthy individual, or a so-called, in inverted commas, healthy individual who would not have been investigated. So, with particular attention to the young, what are the causes in the young? In the young, it should be primary electric diseases like idiopathic ventricular fibrillation, or cardiomyopathies, or myocarditis, or coronary anomalies, some of the inherited disorders. So these are some of the common, the long QT syndrome, channelopathies, all these come into the category of sudden cardiac deaths in the younger population, as opposed to people who are 4 decade and older, where 50% of the sudden deaths are due to ACS and coronary artery disease. In our country, we know that about 25% of the patients with coronary artery disease are below the age of 40 years. So 50% of these sudden deaths are due to coronary artery disease. So that is where our attention should be. So in the older population, of course, structural heart disease, coronary artery disease, valvular disease, heart failure. So in the fifth decade, still in the fifth decade, about 50% of sudden deaths are still due to acute coronary syndrome and coronary artery disease, which we should not forget. The first thing we investigate is the coronaries and coronary artery disease in that angle, unless the diagnosis is obvious either by a strong family history, or you have a prior diagnosis of a cardiomyopathy or some infiltrative disorder, then you do not make a diagnosis of coronary artery disease. But if it is absent, you start with an investigation for coronary artery disease. Of course, there are some confounding causes, even in the young patients, which cause sudden deaths, like non-cardiac causes, massive intracranial hemorrhages, acute brain trauma, exsanguinating injuries, suffocation, toxins, chemicals, massive pneumothorax, massive pulmonary embolism, aortic dissection, and rupture. Most of these conditions are ruled out in the emergency room when patients can reach an emergency room within 1 hour of the onset of symptoms. So, what are the possible triggers? Why do individuals die suddenly, especially in public places while traveling, or during some athletic activity or sport activity, or when sitting quietly, or in an emotional excitement? What triggers these deaths? Most of these deaths are electrical events. When you have a mechanical event like a coronary obstruction, we can easily find out the cause and give it a mechanical or a pharmacological treatment whereby the patient improves. Whereas in an electrical situation, they are very, very difficult to detect. They definitely go under the radar. Like, for example, the long QT syndrome, where on a regular 12 lead ECG, the QT interval may be normal. Only in certain circumstances the prolongation of QT becomes obvious. The Brugada type 2 and type 3 Brugada, where the surface ECG, 12 lead ECG at rest and in normal conditions does not show any abnormality. So, how do we diagnose these kind of hidden electrical dragons? There is no way. But of course, there are some triggers which are known triggers, like obviously the most obvious is the plaque rupture, which gives rise to ischemia. We know that fever and various infections can trigger arrhythmias and sudden cardiac death, especially in patients with Brugada syndrome and some underlying abnormality. Drugs, alcohol, drugs which prolong the QT interval, even sometimes something as innocent as a cough syrup, a beta agonist drug, an inhaled beta agonist for chronic obstructive airway disease. These can promote the arrhythmias. If they have accessory pathways, these simple atrial arrhythmias can turn into fatal ventricular tachycardia or ventricular fibrillation. Of course, alcohol is a well known risk factor for not only atrial fibrillation, but also cardiomyopathies and thereby leading to heart failure and ventricular arrhythmias. Stress is one important factor, as we have seen in stress cardiomyopathy, and also in many of the stressful situations, the catecholamine surge caused triggers of various arrhythmias in a provocable ventricle. Exercise is another interesting thing. We see in the media several athletes, otherwise healthy, playing football, and suddenly, or some other game, suddenly falling dead in the field. So this is another important predictor, both by the catecholamine surge and an underlying abnormality. Many times an accessory conduction pathway or an unrecognized hypertrophic cardiomyopathy or a channelopathy is the cause in patients who die young of a sudden cardiac death. Emotional trauma, which has been seen in many situations, we hear of this. A patient was in a quarrel or a patient was having a heated argument and suddenly collapses. The emotional trauma, certainly, by various mechanisms, again, as mentioned above, can cause sudden cardiac deaths. So, this is a very busy slide, but if you can notice the genetic risks and triggers for ventricular arrhythmias and sudden cardiac death, polymorphic VTs, the long QT syndrome, Brugada syndrome, acute coronary syndrome, infiltrative disorders like sarcoid, hypertrophic cardiomyopathy, DCM. So as the age increases, this is from the first decade up to the eighth decade, you see where they are more commonly seen. The CPVTs, the LQTs are all seen in the younger age group. Arrhythmogenic right ventricular dysplasia peaks in the second decade. Tetralogy corrected chronic coronary artery disease, as we know, is a disease which peaks much later. So this is the exercise thing. This is the athletes thing having that. So this diagram from ESC highlights at what age we anticipate what kind of arrhythmias so that we can start our investigations appropriately. It doesn't mean that older patients should not have an arrhythmogenic right ventricular dysplasia or have a channelopathy. They may survive up to adult age and any age in fact. So, but where we start the investigations, how we lead the investigations, this is a useful guide from the European Society of Cardiology. So, these are some of the recommendations for public. We all know that the placement of a defibrillator in a public place is an extremely important phenomenon, which is very common in the West and has been implemented quite extensively. But in our country, we are still lacking those facilities, though there have been several attempts to place them at airports, bus stands. It will definitely save lives. Because for a mortal electrical event for ventricular fibrillation, no amount of cardiopulmonary resuscitation, no other mechanical kind of treatment will convert this arrhythmia into sinus rhythm. We should always remember that ventricular fibrillation is one arrhythmia which responds only to electrical defibrillation. So, and that is what saves the lives. So that is why that stress on placing automated electrical defibrillators where it should be available to any individual who suddenly collapses, but especially so in places like stadiums or airports or where the concentration of people is more and people are more likely to fall, where there is a sports activity going on or where there's a heavy excitement or heavy crowd or an atmosphere conducive to having a cardiac arrhythmia. So in those situations, it's mandatory to keep these automated external defibrillators. Now, the usage of defibrillators, they have been universalized in that they are very simple steps, or even a lay person who has a little bit of knowledge of BLS or a little bit of ALS can use a defibrillator. So, what are the red flags? How do we start looking at uh, patients and risk stratify them? It is obviously impractical to screen every human being for sudden cardiac death. It's impossible, and it is impractical, and it's also not the right thing to do medically. But there are some red flags which should alert you when you take a history, especially when patient comes to the OPD and asks whether he can exercise or participate in a contact sport or a high intensity training or some such thing. When they are starting off, there should be some red flags in the history. What is that? The most important I feel in this is a family history of sudden cardiac death. If you have a person sitting in front of you and he says a sudden cardiac death is there in the family, in the first degree or second degree relatives, in a younger age, a young individual has died suddenly, it is a big red flag. And you have to investigate these patients to the ultimate conclusive level. Family history of what is presumed as epilepsy, deafness, drowning, accident where long QTs are common, sudden infant death syndrome, heart failure, pacemaker implantation less than 50 years of age, which indicates a congenital kind of abnormality or an inheritable kind of disorder in cardiac conduction. So these are some of the true red flags. But the most important, I would say, is a family history. So you always have to take a family history in patients who present for examination or who present electively, or patients who have survived a sudden cardiac death and you are evaluating them. Most important point is the family history. Of course, clinical examination, erythema nodosum, xanthelasma, palmar plantar keratosis, mitral valve clicks, outflow tract murmurs, these lead us towards particular diagnosis like mitral valve prolapse or hypertrophic cardiomyopathy or coronary artery disease. So this is another slide where it is too small, but I think how do we screen? 12 lead ECG is the basic one. So if you have an abnormal 12 lead ECG, if it shows a STEMI, they get into the STEMI pathway. If it is electrical instability, the most important thing is to first defibrillate the patient and get him into sinus rhythm. Then if it is a STEMI, treat the culprit lesion and they go along a different pathway. If it is not a STEMI, then go for an echo and suspicious for any cause, extracardiac or cardiac, you distinguish them. Do a brain and CT, chest CT scan to rule out any pneumothorax or intracranial hemorrhage, like all the causes we described before, and then go ahead with this protocol and come to some sort of a conclusion. In most cases, like I said, sudden cardiac death investigation is inconclusive. Nothing turns up, just like in syncope, where you investigate, do everything, MRIs, EEGs, various scans, cardiac MRIs, but still you do not come to a conclusive diagnosis about the cause of syncope or surviving a sudden cardiac arrest. But you have to follow an algorithm. Otherwise, you'll end up nowhere and try to do haphazard investigations that will lead you to nowhere. So this is again a very small print. I don't think you'll be able to appreciate that, but you can all get it from the European Society guidelines, which are quite clear about where we should start and how long or how deep we should go to get to the root of the diagnosis. So now a brief word about treatment and what preventive steps and monitoring we are taking to treat this disease. Treatment of ventricular arrhythmias, basically you divide them simply into structurally normal heart and structurally abnormal heart. If there is benign ventricular ectopy, like I mentioned in the beginning of the slide, reassurance, avoid caffeine and stimulants, beta blockers in patients who are symptomatic, calcium channel blockers, and optimized treatment of underlying cause. That is for ventricular ectopics. For ventricular tachycardia, if patient has an acute hemodynamically unstable VT, you first cardiovert them. Do not try to waste time looking into other whether it is VT or SVT with aberrancy. First cardiovert the patient, get a 12 lead ECG which is stable, compare them. That will give you a lot of information regarding the origin of this VT. Of course, beta blockers, antiarrhythmic drugs, there are many ablatable VTs. If we can recognize RVOT VTs, exercise-induced VTs, CP VTs, vascular VTs, many of the VTs can be endocardially or epicardially selectively ablated. So ablation has now progressed quite rapidly with 3D and pulse field ablation. So you should always consider ablation in a where you can find a monomorphic VT with a focus which is ablatable. Of course, devices come next. Implantable cardioverter defibrillator is the definitive treatment for sustained ventricular tachycardia where the circumstances are, where the criteria are met for implantation. So from prevention, from priors to devices, prior to the advent of ICDs, there were no particular things to treat the VT. You used to give them drugs and wait for them to improve, or give them very antiarrhythmics, which themselves were used to cause a lot of arrhythmias there. Every known antiarrhythmic drug is a proarrhythmic drug also. So we should be acutely aware of that. But once the device came in, we moved from priors to devices. We should understand that ICDs save lives, about 30% or more reduction in arrhythmic deaths, very significant mortality reduction across several primary and secondary prevention trials. There is absolutely no doubt about that. A very low number needed to treat. If you treat 9 patients, you will save one life. And one of the most underutilized therapy in cardiology, because the understanding is lacking among not only among the general public, the awareness is less, the cost of therapy is more, especially in our country where economics play a role in how the patient accepts treatment. So angioplasty is easily accepted, but therapies for arrhythmias are most underutilized. So choosing the patients for primary and secondary symptoms, secondary prevention, you should carefully choose by history and risk stratify them, because otherwise you'll end up putting a lot of devices with no benefit. Many patients receive device therapies. If they are not properly selected, they'll have a device and no shock through their entire lifetime, then it would not have served the purpose. So symptoms, giddiness, syncope and syncope, NYHA class, the higher, the lower the NYHA class, the higher the risk of sudden cardiac death. The higher the NYHA class 3 and 4, more deaths are due to pump failure rather than arrhythmias. Asymptomatic high risk patients, first symptom may be a sudden cardiac arrest. So never leave a patient because he's totally asymptomatic. But if they have high risk, consider implanting a ICD because it definitely saves lives. So as simple as a 12-lead ECG can recognize long QT syndromes, Brugada syndrome type 1, hypertrophy patterns, prior MI, arrhythmogenic right ventricular dysplasia, very easily recognized by subtle signs on the ECG. Not going to totality of it. This is one ECG of a Brugada syndrome, that RBBB pattern and pseudo ST elevation in V1, V2, V3, which is quite classical of type 1 Brugada. Echocardiography is the next single most important factor, as LV ejection fraction seems to determine everything. It's an independent predictor of mortality and morbidity in patients, how they progress and how long they live. And whenever there is an ejection fraction less than 35%, they become primary indication for preventing an arrhythmic cardiac death. We move on to Holter, where you have several high-risk features, including QT dispersion, the kind of sustained and non-sustained VTs. We also have implantable loop recorders, and now the more popular ones are the wearable devices. Many patients are now coming to our patients with their wearable devices and saying that I have an arrhythmia or have a high heart rate or a low heart rate alarm. Please look into it. So many of the patients are coming like that. We should use the modern technology combined with artificial intelligence and try to diagnose these arrhythmias. So it has become more easy because patients themselves are becoming more and more aware. Cardiac MRI shows late gadolinium enhancement. It's a good indicator of scarring. If there is a high amount of scarring, about more than 5% high risk for SCD. But if too much of ventricle is scarred also, then there may not be much benefit from a ICD. So we have to select your patients. So most patients will have that benefit with a single chamber ICD, especially when pacing is not required. If pacing is required and there is any degree of left ventricular dysfunction, then you should choose a CRTD. A dual chamber ICD if pacing is required and ventricular function is normal. If LBBB pattern and LV dysfunction, consider putting a CRTD. And now we have more physiological pacing methods, which is left bundle pacing. His bundle pacing seems to be more physiological and cause less pacing induced ventricular dysfunction for a long period of time. So that is what we choose, especially for the younger individuals. There are several recent advances in devices, and I'm sure you would have been familiar with them. Most of the devices are now MRI compatible. Doing an MRI in a patient with pacemaker or an ICD was a challenge earlier, but now not so. After 2017, I think every ICD is almost 99% of the devices are MRI compatible. And the devices are intelligent. You can read them from the surface and also interrogate them remotely. Leadless subcutaneous ICD are now available. Bluetooth connectivity and real-time monitoring is actually live now. Remote programming is possible. A leadless CRTD has also been implanted. First implants in humans have been done. And now transcutaneous charging and even the solar cell charging have come through. And the nuclear kind of devices have come, almost 600 implants with a nuclear powering has come, so that once you put a lifetime, it can be for a lifetime. Once you implant an ICD or a pacemaker, it can be for a lifetime. There are also wearable ICDs for patients who are waiting for an ICD in the mandatory period post myocardial infarction, like say for 42 days after an MI, you had to wait for that period. So if the patient demands that what happens to me if I have an arrhythmia in that period, they may have a wearable ICD vest, which is protective and can give shocks. Only problem is it cumbersome to wear. Patient have to remove when they have a shower, and it's quite expensive to use. So this is an example of a leadless subcutaneous ICD where there is a retrosternal lead and there is a pacemaker box which is kept under the chest. So it is not truly leadless. It has a lead which is placed retrosternally. It is leadless in the sense that it does not have a lead in the inside the heart. So this is a example of leadless CRTD, which is an interesting device. Leadless CRTD again. So why underutilization? Only 40% of indicated patients actually receive an ICD, much less in the Indian population. Physician awareness is also low. Many of the physicians are unaware of that. The cost concerns, of course, and availability of skilled physicians. These are some of the identified factors. So thank you all for the attention, and I hope that there were some interesting points to learn in this lecture on how to select and how to risk stratify younger patients, especially who have sudden cardiac deaths, and thereby prevent sudden cardiac deaths in the younger population. Thank you all for the patient hearing.
Thank you so much, sir, for this wonderful presentation. We do have some questions if you'd like to take that up. So, sir, the first question is, are we
Yeah,
underestimating the true incidence of SCD in the young due to lack of sympathetic report or autopsy data?
absolutely. Especially in our country, many of the deaths go unreported. Many of the deaths are unattended to, and especially in the rural or remote population, there is no formal autopsy, or even they won't see even a healthcare personnel. So in this situation, there is a lot of underreporting in our country, especially with respect to sudden cardiac deaths.
Next up, we have, sir, how do we balance the benefit of screening against the psychological and economic burden of false positives?
Yeah, this is one important question. And when we screen, especially younger individuals, and find something like if you do a genetic screen and find that they are at a risk for cardiomyopathy, how to counsel these patients and what kind of therapies we advise for these patients becomes an important challenge. And of course, if you recognize a very high risk feature, then you can tell them that this therapy will be life saving. Then it is easier to convince. But if you find a disease and they do not have any other high risk features like sudden cardiac death history or high risk features on Holter, then it becomes a real challenge. So this is where a physician's role becomes crucial in judging what is real time, what is beneficial for the patient, and where we should implant a device and how we should counsel a patient. Of course, now with the advent of artificial intelligence, everybody knows everything. They can interrogate themselves, their own history using AI and come to some sort of a conclusion. But still, the physician has to play a paternal role and give the appropriate treatment for the right patient.
So, one last question. What red flags in a routine examination should prompt a deeper cardiac evolution?
Absolutely. Like I mentioned, there are several red flags. One I said that I stressed upon is the family history. If the family member has died at a young age with a sudden cardiac death or of a documented arrhythmia, I would put it as the biggest red flag. This person definitely needs to be investigated. And to what extent do we go? Do we just do an ECG, echo, and a 7 day or a 30-day monitoring? Is it enough? No, we would go a little bit ahead, especially if they have a positive history. go for a longer recording or even implant a loop recorder if it can pick up some arrhythmias and save lives. Do a cardiac arrhythmia, cardiac MRI, and rule out any infiltrative disorders, hypertrophic cardiomyopathy, sarcoid, rhythmogenic right ventricular dysplasia. We would go one step or two steps forward to rule out all possible arrhythmic causes in this particular individual. So you should watch the red flags and take them serious.
Thank you so much, sir, for answering all our questions. That's all from our audience, sir. Before concluding, any take-home message from your end?
Yeah, the take home message I would like to give today is that prevention of sudden cardiac death in the younger population is an extremely important topic, and every physician and cardiologist should take it seriously. And whenever you see a person with an arrhythmia or an implanted device, you should also look at their families. Many times we ignore the caregivers. We do not inquire about what is happening to the children or to their parents. Both ways, we should look at them. And when a clinic visit is a very important opportunity for the physician to enforce all these ideas on how to screen what diseases can cause sudden cardiac death and thereby use that opportunity to save lives.
Thank you so much, sir, for this wonderful presentation, and thank you for joining us today. It's a pleasure to have you here, sir. Thank you so much.
Thank you.
Thank you, sir.